Order, order. Welcome to today's meeting of the Health and Social Care Select Committee and the first session in our inquiry into community mental health services. Throughout this inquiry, we'll be examining how we can improve access to, the quality of, support provided by community mental health services, as well as how services work with organisations outside the NHS to address the wider health and social needs of people with severe and enduring mental health needs. We've received over 240 pieces of evidence so far. That's a lot in the context of a Select Committee inquiry, and we expect to receive many more. And throughout this inquiry, and indeed in all our work as a committee, we are committed to putting services, people who access these services, their families and their communities at the heart of everything we do, to understand what high quality care and support looks like from their point of view. So it is therefore with delight that I welcome our very first panel of our very first session of this inquiry, and we will be hearing directly from three experts by experience. So may I start by asking you to very briefly introduce yourselves, starting with Ian Callaghan.
Thanks very much, Leila. My name's Ian Callaghan, with experience of severe mental illness, as you'll hear. Thank you very much for the opportunity for being here.
Thank you so much for being here. Francesca?
Hi, my name is Francesca. Also have experience of mental health services, as you will hear from me as well.
Thank you. And Chris?
Good morning. Chris Frederick, suicide attempt survivor, global citizen and mad Star Wars fan.
You and I have that in common. So may I start perhaps with Ian first, if I may. Could you briefly, and I appreciate this is a lifetime of experience you're bringing, but as briefly as you can, tell us your experience of accessing mental health services.
Certainly. It is a long story, but I'll try and keep it brief. My story is about 40 years old, since my early 20s, when I had my first episode of severe mental ill health. Again, a bit like Chris has just mentioned, suicide attempt survivor. And I've experienced community services most of my life since then, intermittently, episodes of good mental health, as it is at the moment, but episodes of very poor mental health. I've received many forms of treatment from many different care teams. And at the moment, if I fast forward to the present day, I don't have a community mental health team at the moment because I'm deemed to be too well, which is one of the things that we'll probably come on to a little bit later, which is that there can be a bit of a, sometimes people call it a bit of a cliff edge, that when you're deemed not to need certainly a secondary, so-called secondary mental health service, then often you're discharged, and discharge can be very anxiety-provoking, feeling that you're sort of left without the support which has helped get you well and keep you well for many years. Fortunately, I have an excellent GP, which I think is something which you benefit from, and know that I have the port of call if I start becoming unwell again. But unfortunately at the moment, as I say, I've been discharged for just over a year, about 18 months. So my experiences are very varied. I've had community mental health services provided by secondary care teams, so that's ranged from just occasional visits to a psychiatrist to having, when I last came out of hospital, having a full care team, which was psychiatrist, CPN, community psychiatric nurse, social worker, psychologist, which I'll come on to later, I think, to tell you a little bit more detail. So I've had a very varied range of experiences, some excellent, some very poor, and as I say, at times none at all. Have experienced long waits for to be seen. Before my last admission to hospital, which was a long admission to hospital, I was very ill. I was in crisis and went to the GP, and unfortunately the GP didn't really know what to do, tried to contact the secondary team, and it was a 6-week wait to be able to see a psychiatrist, and that was when I was in quite considerable crisis. Another problem is that crisis teams often don't accept people who aren't known to a secondary service, and so I wasn't eligible to be seen by a crisis team, even though I was very clearly in crisis at the time, and that led up to a very long admission. I spiralled downwards very quickly and very severely, one of my worst episodes, and needed admission to hospital. That again probably come on to a little bit later about strengths and weaknesses of services, that I do think that there could have been a much better service that could potentially have prevented a long admission to hospital.
Thank you so much, Ian, for setting the scene there. And yeah, we'll have plenty of time for follow-up, but thank you so much. Francesca.
Hi. So I have a lot that I want to say, so I'll try to get through it pretty swiftly. So my experience accessing community mental health services has been highly fragmented and frustrating experience. One of the most exhausting aspects is the constant need to explain personal circumstances repeatedly to different professionals. So each time support's sought, you have to recount a full history, what's been tried, what's worked, what hasn't worked, and what's still needed, because there's still no effective continuity between services. It often feels like starting from scratch with every new professional, which is not only emotionally draining, but it's also a significant barrier to effective, rapid, informed care. Another major issue that I've noticed is the often complete lack of follow-up. When SMI symptoms have been identified and services have been accessed, there's often no ongoing support to check for improvements, assess changing needs, and determine if additional help is required until a crisis point is reached. Additionally, for those struggling with mental health, maintaining physical health can become an insurmountable challenge. I've found that there's no additional mechanism to ensure attendance at medical appointments, blood test scans. This leads to worsening health conditions that could have then exacerbates poor mental health and builds an overall health anxiety, which could have been prevented with proper support. The absence of this kind of coordinated approach that I've noticed means that the burden falls entirely on the service user to navigate these multiple disconnected systems at a time when it's least manageable for them. One of the most concerning aspects that I've noticed is being dropped or delayed from accessing services. Due to a lack of response, SMIs make it difficult to respond and calls and emails. Yet instead of recognizing this as a symptom that requires greater outreach, individuals that struggle the most are most often ignored and excluded. There's little to no effort to ask service users about what's your preferred communication method, that results in worse mental states being left without support. So you end up being then the most underrepresented and the most underserved when you're in the most vulnerable situation. I've also noticed that, as everybody has noticed, waiting times to access the support is really unreasonably long. And then when services are actually received, they don't fully address individual needs, so they still feel very generalized rather than personalized. So they don't take into account the wider social conditions, physical health conditions, and the cumulative toll that it takes on a person to repeatedly try and fail to get adequate help. That exhaustion, the long gaps between the appointments also contribute to this lack of continuity, which makes it difficult to build trust with a single provider. And without trust, engagement with treatment becomes then even harder, and concerns may go unrecognized and misunderstood as the person becomes more jaded to the system of trying to access help. Financial barriers is another thing I wanted to mention that further complicate access to necessary care. So when you're struggling with your mental health conditions, you face challenges securing stable employment, but you're expected still to cover costs of multiple different medications and transport. Assistance in navigating financial aid and coverage options and access to essential treatment becomes unsustainable. this creates the cycle in which individuals are unable to afford their medication and they experience worse mental health, and it further limits the ability to work and then further limits the ability to support themselves. So, there's also significant weaknesses in how wider needs are considered in mental health care overall that I've noticed, that social determinants such as like housing instability, employment struggles, and financial insecurity, they're rarely addressed within the treatment framework, but they impact so much in one's ability to manage their mental health conditions. There's minimal recognition of how these external pressures exacerbate the conditions, and it leaves service users without a holistic support. And programs to address both physical and mental health, they're becoming more common, but they are still rare, despite being the most effective in providing like this comprehensive care. So these are all the things that like I've noticed in my experience.
Thank you so much, and we're really keen to hear more specifics about that as the session goes on. Thank you so much. Chris, over to you.
I think Ian and Francesca have said everything I was going to say. Which actually is a good thing, because it means that we're all experiencing similar things. But, following on from Francesca there, I've always felt like a case number and not a real person throughout this entire process, which is perhaps not as long as my two colleagues here, but whether I'm visiting my GP or being visited by crisis teams or therapists, each time I have to relive my trauma of attempting suicide, because they're asking the same questions over and over again, and I have to repeat that. And it is very traumatic. There doesn't seem to be, again to Francesca's point, it doesn't seem to be much continuity of care, but also the communications between all the different services. They seem to be operating largely in silo and not integrated, which causes folks like us a lot of undue stress. When I returned from Asia in 2018, I found the system completely fragmented. I'd lived all over the world, in Asia for 20 years, and I had experienced what I consider impeccable support and care in very small locations like Singapore. So I expected when I got back to London that I would largely receive something similar, but it was completely the opposite and very disappointing, to be quite honest. I think about an analogy of walking through a maze, and we're not talking about sort of Hampton Court size maze here. We're talking about Harry Potter and the Goblet of Fire type of maze, which is very scary and very daunting, where you're trying to figure out where do you turn, left, right, do you go straight? And despite some of the referrals and recommendations and lots of content on social media, you should try these different techniques, you really are on your own. There's nobody there to support you, and often you're pretty blind to what, it's a lottery, what you're actually going to receive. I've asked countless times when going through CBT, can I please speak to a black therapist? And the answer has always been, we don't have one available, but if you're insistent, you'll probably have to wait a year. So either accept what we give you, or, wait. And so I've gotten so used to hearing the word no that I just accepted it. And it wasn't until early last year, it was by pure chance. I happened to be glancing through my feed on LinkedIn, and I saw a post from Black Minds Matter, great charity, and they were offering 10 free sessions for black clients to have a black therapist. And I thought I'd won the lottery. So it was just so exciting, and for the first time in a long time I felt real hope. So I immediately jumped on and referred myself, and the whole process from initial email response to the final 10th session, it was life-changing. But that's somebody who is technically very adept on social media. The question I ask myself is, I could have missed that post on LinkedIn. So what about everybody else out there? How are they going to know that opportunity is available to them. So the other thing as well is that I'm somebody who likes to take control of my destiny, despite what's happened. And so in between all the different months I've had to wait for therapy, I've had to go out and research the industry. And what I managed to find were what I call buffer services. And again, I don't know how many people in my position actually know of these services, but I mentioned organisations that were just superb, like the Listening Place, James's Place. They were there for me to buffer the 6 months gaps while I waited for CBT. So I felt that journey, that self-recovery journey, was very much down to me. But if I could teach that to all the black men in London, I tell you, they'd be chewing my arm off, because they wouldn't necessarily know all the different services that are available. And there are some outstanding services out there. But what we're not doing is we're not communicating that, and we're not bringing that together in one kind of central resource, repository, hub, whatever you want to call it. Systems being primarily reactive. Care came only when I reached breaking point and not before. This is life-threatening stuff we're talking about here.
How did you access that care at that point? What did you do? Was it a GP? Was it a friend or family that intervened on your behalf?
I'll be honest with you. I took an overdose. And it wasn't until I was admitted into Ealing Hospital and I saw the clinical psychologist, and then the crisis team came to visit me, it was only then that they started to share and recommend different opportunities, different places I could go. I didn't know anything before that. It took, even my mum would say, maybe this was a call for help. It was, I don't mind saying it was a call for help. But it wasn't until that moment I realised that there were people out there that could serve my needs. But I had to go to that length.
Thank you for sharing that. That's difficult to share. And Ian, I notice you're nodding your head at that. Is that similar to your experience?
Absolutely. Sometimes you do have to go to such awful... You fall to such depths sometimes without the right support and without accessing, as Chris said, without knowing where to go. And there are places to go, but if you don't know where they are, nobody's telling you, nobody's supporting you, and sometimes you just get into such awful depths of despair. And I've also self-harmed in that way when particularly unwell, and it's only at that point that you sometimes do get held and get helped, which is, it's a medical emergency, and people don't realise that we are talking life and death, and we are talking similar degrees of crisis to physical health crises that get managed, hopefully in some cases, in a timely way, but there just isn't the timely support for people. Having said that, I was under a good care team. I mentioned I have had some very good care, and I was under a secondary care team that had a crisis team attached to it. And because I was known to the team, they could make the referral that then would be guaranteed to be accepted by the crisis team. It was one Christmas which I used to find particularly difficult time of year. And the crisis team were excellent. They visited every day, not for very long, for 15 minutes sometimes, but that was enough. And that sort of got me over. But I know that in other times when I've not been attached to a community team, I've not had any crisis support whatsoever, because they just won't see you, and that's when things spiral out of control sometimes.
Well, thank you. And Francesca, you spoke about social determinants and wider support for the person, the whole person. And you mentioned physical health, but you also mentioned housing and sort of financial help and support. Did you find that there was anything out there for you in those cases? You were asking for this and it just wasn't there? Or is this in hindsight, that would have helped? I just wanted you to dive into that a bit more. And also, Chris and Ian, if you've got experiences of, the wider social determinants that might have helped you recover faster? We're very keen to hear about that, but Francesca.
Yeah, I mean, it's definitely something that I've asked for and that I haven't, did not get any kind of...
Who did you ask when you asked?
Asking my GP, just kind of like mentioning as well, the most help that I've ever gotten that has been useful has been from like these small charity kind of groups, and that my other two on this panel have been mentioning. Being able to access those little services has been the thing that keeps you going, because the actual system itself with GP and with mental health services is not the thing that is providing that sustained safety net for you to be able to grow and actually, improve what's going on with your situation. Mm-hmm. So, yeah, it's only been kind of references that I've gotten from other smaller charities which have been able to help me, not from the GP and not directly from other mental health services.
What kind of help did they provide that was useful?
Providing actual sessions, providing inpatient treatment, providing different recommendations to other charities that would help.
What and about what? So in housing, for example, you mentioned housing specifically. What did you need, and what?
Well, what I mean by that is kind of an overall, being able to have a sense of financial independence and feel like your creativity and talents are not being looked over. Right. So for me specifically, the encouragement that I've been able to get about applying for different roles and things like that has been from charities rather than from kind of any referral that I've gotten through the actual mental health care system. Mm-hmm. So that kind of support has not been there to kind of push all the other elements of life forward that would benefit mental health.
Chris and Ian, very briefly.
Yeah, I've come into this space having spent nearly 30 years in the private sector. Mm. And so as a lived experience advisor, I often have quite a different perspective on the rudimentary ways in which I believe the sector should operate. Mm-hmm. and it's those within it. And I keep coming back to this one word, which is communication. It's the failing that all these different experiences and resources that are out there are just often just hidden. They're masked behind, complex websites and all this sort of stuff. And really, the average Joe on the street, when I live in northwest London and in Kensal Green, and if I walk around my neighbourhood and go to my local job centre and I sit there and I look at the notice board, which is empty, and that's where foot traffic goes. Mm. I go to the library, the community centre, I occasionally would visit the church. None of these places have any posters talking about, if you are experiencing mental health issues, signpost you to here. Empty churches are sitting empty, and I sit there and I think, what a beautiful place this would be for something like a healing circle, where you could invite a dozen people to come along on a Wednesday afternoon and just sit and talk. Mm-hmm. Because at the heart of all this is something that very few people talk about in this industry, which is chronic loneliness and social isolation. Mm-hmm. At the most unhealthy level will be life-threatening. And again, that's something that I also suffer from. And I actually sit as an advisor to the National Campaign to End Loneliness, mm-hmm. as the only lived experience person, but also the only person of colour in a group of experts. And I'm constantly saying to all of these individuals and many others, we need more people that look like this, that are brave enough and vulnerable enough to tell us exactly what's on their mind, mm-hmm. and really advocate for change. And that's what I do every day. And it's not easy. I do it on my own in my room, so sitting here next to these two today is just a blessing. It really is.
Thank you. And we are so grateful to all of you. Greg Stafford.
Thank you very much. And I think you've very eloquently described the things that have gone wrong. So what do you think good quality care in, specifically at a community-based care and support, what does that look like to you? And have you got any specific examples where you have received good quality community-based care and supports? Ian, you want to go first?
Yeah, as I mentioned, I had a long period of time in hospital, and I think partly as a result of that, and it just happened chance where I lived, where I was discharged to, happened to have a very good, well-developed community team. And this was in the days when we had things called CPA meetings, Care Programme Approach meetings, which you probably have heard of. And I had regular meetings with my psychiatrist and CPN social worker every 3 months. As I say, I had a fantastic GP as well. They liaised with each other. They kept tabs on how I was. The last thing we wanted was me to be readmitted. I was on a waiting list for psychology. I was discharged and said there are no psychological services available, but 18 months later on a waiting list, I did get some therapy on the NHS. I had some managed to pay for some privately in the meantime. But there was access to an occupational therapist for things like finding out things to do in the community, a bit like Chris says, there's just often the information just isn't out there. So I had somebody who did have a connection with the community that was really very helpful. I was discharged into supported accommodation, which had pros and cons, but did support me in many ways until I was kind of fully back on my feet. I was very fortunate in that I did have somewhere where I could volunteer. I wasn't ready to go back into employment at that stage. There was a local recovery college which I attended, which was very helpful. There was a local peer support group that again was very helpful. It was a Rethink mental illness peer support group, so we have a sort of a national network of groups, but it's only we don't have one everywhere, and there isn't one everywhere. But I found that very helpful. So those are some of the things. That's not everything, but those are some of the things that I found particularly helpful. Unfortunately, as I say, the sort of more you are for longer, the less what you get. And you can sort of understand why that is, but then you get left to your own devices, and that's often because we're talking about people living with severe mental illness. These aren't things which are kind of just passing. These are the things which are enduring, unfortunately, for many of us.
Thank you. And Francesca?
Yeah, I mean, so I also experienced Recovery College, which was very helpful. There was a program that Mind Charity ran, which was philosophy for mental health. That was really, really great. It was a fantastic experience because it's not just taking different philosophical approaches, which really suits some people, but also it's just the sense of bringing people together consistently who knew each other, had similar struggles, had similar experiences. And the issue with those things, I mean, they're brilliant, lots of different kinds of little experiences like that I've had, which have been really great. But then once you kind of get into a program like that, it lasts for so long and then it just kind of dissipates. And as much as you try to kind of continue it, people form WhatsApp groups, people try to continue. Without that kind of structure and support around it, you then kind of lose it. So, and then there's no kind of follow-up on from that. You never hear about the program again, so you don't know if it's just something that's one-off, if it's something that's going to be repeated in the future. Is it part of you would hope that it's going to be part of a wider pathway to working on your mental health and challenging severe mental illness. What great care and support looks like to me is having that comprehensive system where you are on a pathway and it's not just a very short kind of you're going to get X number of sessions and then that's it, but that you're on this pathway that's got a longevity to it, but that does have structure to it, but that's really personalized to the individual. Some people might not find any value in doing philosophy for mental health courses, but me in particular, that's my kind of, the way that I like to approach things. So it's about that personalization that really needs to be integrated into the kind of support that each individual needs.
Thank you very much, Francesca. Chris?
Yeah, I mean, great question. What does good look like? I experienced good once I was discharged from Ealing Hospital, but it lasted 6 weeks, and after that, the baton had to be passed on, right? Yeah. I love recovery colleges as well. The Brent Recovery College that I attended for about 18 months was superb. The courses they ran. I'm a big techie. I love artificial intelligence, and I close my eyes sometimes and I could imagine I had an AI assistant that was here that had my entire case history in their file, and any time I had a question or I was feeling a little bit low, or I needed to find a peer support, a Frisbee football peer support group for men on a Saturday at Hyde Park, my AI assistant would say, actually right now from where you are, Chris, that would be a really great opportunity for you to hang out with some guys and talk about what's going on in your lives. Unfortunately, we don't have that. But what I've got to do is I've got to try and find all those different opportunities to share care and basically talk. And it's not easy, particularly when you do, when you're suffering from that social isolation, that loneliness piece. It can be quite scary to go out and meet strangers and have those sorts of conversations. So, but AI, I think, is what we need, something like that.
Thank you very much.
Thank you. Can I ask a question about medication management as well? Because you guys spoke about talking therapies and CBT and psychiatrists and psychologists, but we do know that it's quite specialist prescribing, and your GP is the one who's sort of the ongoing gatekeeper. I'm seeing both Ian and Chris furiously nodding.
It's such a good point.
Perhaps Chris, carry on, and then we'll go to Chris and Francesca.
I actually completely forgot about that until you mentioned it earlier. I've been on anti-anxiety and depression meds for about 4.5 years. And actually, it's funny because I don't think about it, but I take them every morning, and nobody has reviewed them in 4.5 years. Nobody's had the conversation with me. So I don't know that, to Ian's point, if I'm feeling better and I start weaning myself off those meds, what's the impact going to be to me physically and mentally?
Anyone ever talk to you about the dangers of doing that?
No, not at all. And nobody ever mentioned to me about the side effects of these medications.
Wow.
And I know I don't look it, but I just turned 55 a couple of weeks ago.
Don't look it.
Birthday.
Thank you. And certainly I've put on a lot of weight in the last couple of years, and the blood pressure's getting dangerously high. But I don't know if these meds are contributing to that, or it's diet and the meds. I'm not doing a lot of exercise, but I just don't know enough about this stuff and even question it. So every morning at 9 o'clock, I pop my meds and just carry on. There you go.
Thank you. Ian?
That's something that worries me as well, really, because the last time when I was moved from the very good care team that I described earlier to the one which was okay, but the one that subsequently discharged me because I'm too well, the last time I saw the psychiatrist, they increased my medication because they thought I wasn't doing quite so well, and I would do better, and indeed I did do better with a slightly higher one, particularly antipsychotic medication, but I haven't seen a psychiatrist since then. My GP doesn't want to do, which I think is often the case because GPs aren't so specialist and they defer to the specialist, doesn't want to change it. I've kind of done reading about reducing the dose, deprescribing, but don't want to just in case. So I'm kind of left a bit high and dry, not being part of I don't have the connection with the psychiatrist anymore, and if I were to have one, I'd have to be re-referred, go to the bottom of the waiting list and start again. And the other thing as well is that if you develop other I'm even older than Chris and starting to develop.
Don't look it either.
Starting to develop other physical conditions, and the GP's kind of, I'm not sure if that'll interact with this medication. I'm not sure if it'll interact with that. I can't give you this, even though I'd like to, because of that. And I don't want to touch that because it's not my remit. And I mean, I am fortunate in that I have annual physical health checks, which not everybody gets, but about 60% of us do, which is great. But it should be 100% of us getting them. And so it does keep an eye on certain things, but it still isn't the same as having direct support for those things.
Did that psychiatrist who prescribed it initially, were they known to you? Had you been...
No.
That was you saw them once. They prescribed antipsychotics and then that's it.
Increased the dose and that was it, yes. Yeah, but that was when I did have a monthly visit from a care coordinator, but I said, and she was very honest and said it was her manager that was going through a caseload and said, I think you don't need to be seeing Ian anymore, and so 6 weeks later that was it. So and that unfortunately is happening.
You want to add something?
Yeah, I mean, it's a similar story, like, been on certain medications for ages with no review, like for years. One of them in particular for like 6-7 years, no reviews at all to kind of see, is this the right level? Is this not? Every time I just kind of push the button, to request it from the GP, here it comes again, without any kind of review system in place. And then, when I have been to kind of talk about other potential medications, recently I was prescribed one, and it wasn't until I got home and I looked it up and I was like, wait, I tried this medication. That's in my history that I've tried it before and had horrible reactions to the side effects. So here
was it GP who prescribed that? Or
no, that was a specialist.
Who
had to go into the system and look through the system to figure out, you have actually been to this location before, and me having to like recount everything and him trying to understand as quickly as possible what I've actually already tried. And in all of that, it was missed that I had actually been on that combination of medications he wanted me to try and had really bad side effects to it. So that whole kind of appointment wasted, because then I can't go forward with this prescription that I've gotten because I'm not confident about it anymore because of my knowledge of the history, which I only figured out after the appointment. The other thing that I've kind of noticed is just that, it's that lack of like knowing what you've already tried. There's a lot of medications that they have suggested to me as well, but there's always that kind of like Ian's mentioned, there's always that kind of, this is going to cause a lot of rapid, huge weight gain. Mm-hmm. Okay. That's already something that I'm struggling with that's having an impact on other medical conditions. Mm-hmm. Why would I then want to exacerbate, so then it's like all of the choices become very limited, and are not thoroughly reviewed with all of the rest of your medical situation of what you've already tried and what other medical conditions you're trying to balance.
Thank you.
Thank you very much. Again, a question to each of you. Thinking of the experiences you've had, what one thing would have made the biggest difference? And if you can't think of what, if 2 is easier, fine. What 1 or 2 things would have made the biggest difference to the care and support you would have received?
For me, I go back to the time, that crisis before my long stay in hospital, and it would be not having to wait for so long for referral from GP to psychiatrist or some specialist support, knowing where else to go, the GP having a bit like, Mr. Francesca mentioned, having somewhere else to go to get support, not feeling completely bereft, disconnected on your own. My partner at the time was calling he got the number for the crisis team, but they didn't want to know. The GP was saying to me, what would you like me to do? I was saying, well, do something, at least, and did, but it was 6 weeks later, and by then I was, extremely, the most unwell that I've ever been. I didn't to be honest, I didn't think to go to A&E. Nobody said, how about going to A&E? I just didn't, I thought I haven't got a physical health problem, therefore I won't bother them. So to have systems that are more responsive, that talk to each other, that have the same IT system, that, so that surely there must have been a better way, and that could have potentially, it may not, but I think it could have preempted a very long admission to hospital.
Thank you. And Francesca, what would have made the biggest difference to you?
Having one point of contact that I would have been able to go to, that I would be able to go to, where what I've tried and what I'm working on and working towards is all kind of managed through that person in a personalized way. So being able to, I'm a very creative and ambitious person, and I'm not doing work consistently right now which fulfills that creativity and that ambition. So that's having a real negative impact on my mental health conditions. And so being able to kind of sit down with that person and say, here's the list of like the different areas where I think if I had improvement on, I would be able to get to a state where I would be in a really good and mental health state, where I wouldn't be feeling the impact so much of the SMI that I'm struggling with. So I think all those things, being able to just have that consistent communication with one person and being able to actually co-create my plan for this is like what I need to have that improvement in all these other areas, which, which will have a massive like positive impact on my overall health, physical and mental health, which then will give me such better prospect for being able to seek out any kind of additional help that I need in the future.
Yeah, very, very useful. Thank you. Chris?
The Friendship Bench. Have you heard of it?
No, but I hope I'm about to.
It's from Zimbabwe, started in 2006 by Dr. Dixon Chibanda. And right now, I'm supporting the project to bring the Friendship Bench to London for the black community. It is a community-led, peer-supported mental health initiative. This model removes clinical barriers and provides accessible, human-centred care in local spaces. In Zimbabwe, they have trained over 3,000 grandmas. The eldest was 95, who died last year. And when Dixon started this in 2006, he had a budget to train 16 grandmas because they have the most beautiful EQ. Yeah. And individuals would book 6 sessions to sit on a friendship bench and go through basic level problem solving and trying to understand what are the real issues. And then the grandma would signpost that individual to clinical care. So as a buffer service, this is one of the most beautiful community-led initiatives I've ever come across, recognised by the World Health Organization and the Clinton Initiative globally. And it's opening all over the world slowly but surely. So working with the London School of Hygiene and Tropical Medicine right now, we're hoping that by the end of this year, we will be able to bring the Friendship Bench to London for the black community. That could be a very real game changer.
Thank you very much. Thank you.
Thank you very much, all. That's the end of our time with you this morning. We're going to suspend the television broadcast just for 5 minutes so that we can swap over the panels. Order. Order, order. Well, welcome back to our second panel of today's session. We're delighted now to have even more experts in front of us, and I'd like to start by asking you all to introduce yourselves very briefly for those watching, starting with Lucy.
Hello, I'm Lucy Schonegevel. I'm the Director of Policy and Practice at Rethink Mental Illness, a national charity supporting people severely affected by mental illness.
Thank you.
Hello, I'm Courtney Buckler. I'm Senior Policy and Campaigns Manager for Ensign.
Thank you.
Hi, I'm Harry Dyson. I'm a peer researcher and public involvement officer for the McPin Foundation.
Thank you.
Hi everyone, I'm Kadra Abdinasir, Associate Director for Policy at Centre for Mental Health. We're an independent charity with a mission to tackle mental health inequalities through bridging the gap between policy research and practice.
Lovely. Well, thank you all. You heard our very erudite and moving panel up front. I wonder if I could just ask for your very brief reflections on what you heard, perhaps starting with you, Lucy.
Yeah, thank you. Well, first of all, just really commend the committee for putting lived experience at the forefront of this inquiry. And I think, there's so many reflections that I think we will talk about a lot in this, but my utmost reflection is if Chris, Ian and Francesca were at the centre and at the decision-making table on what care should look like in the community, I don't think we'd be here investigating this with the same experiences. I think we'd see a very different system, really compassionate, caring system that supports people socially as well as mentally and clinically and keeps people well and out of hospital.
Thank you.
Yeah, I don't know if I can keep it particularly brief. I'll try.
Do your best.
Here's only one of the long list of things I have to say. I think a thing that was a very common thread throughout what people were sharing and what we know from our membership as well is the extent to which the burden of achieving good care is falling upon individuals themselves. And that is especially difficult for anyone facing any kind of trouble with their health, but when the context of that is mental ill health, distress or trauma, that cognitive and emotional labour of advocating for yourself repeatedly takes a different kind of toll. And that there is a dynamic that you will see happening, which is, if people can't keep up with their care, they might not be attending appointments, they might miss things, they will be penalised for that. Sometimes that will be called non-engagement. Sometimes they will be, discharged for services because they didn't turn up. How are they supposed to keep up with, X, Y, and Z? Then on the flip side, what you'll have is, with an NHS in crisis and more people also in crisis seeking support, there is this increased language around high-intensity users, frequent flyers, this kind of problematization of people who are just being advocates for their own care. There are people who are saying, I don't think you should prescribe me that, or I'm not going to take that. That then will be non-engagement, that people who haven't had support will be pushed further into crisis, will be turning up at A&Es, will be seeking more support in increasingly distressed states. And what we find is kind of interventions, innovations, of which I can list many, that are being trialled in the NHS to essentially dissuade people from advocating for themselves and punishing people for the crisis that they're being pushed to on account of poor health.
Can you give us a specific there?
I can, yeah. So there was a programme called the Serenity Integrated Mentoring Programme, which was a for-profit programme delivered by or innovated by an ex-police officer, and that was being rolled out across NHS trusts. That was to do with people in mental health crisis turning up at A&Es, and that was a new innovation which would put police officers into A&Es and basically punish people with fines in multiple instances. If you turn up again in X amount of time, you will be fined. There were, collectives of activists who were actually fundraising to pay these fines for people. The successful halting of these programs was not something that was acknowledged or recognised internally. That was the unpaid labour of activists supported by Ensign and many other people in identifying this, and it was in fact halted by NHS England through the quite frustrating process of people who are themselves in crisis, identifying this and calling it out.
Thank you. That's very
Thank you.
Yeah, thank you. Yeah, some really powerful testimonies from the first panel. As a peer researcher, I work from a lived experience perspective myself as well, so a lot of the things discussed on that panel resonate with me on a personal level as well as sort of professional level in our research work. I think, yeah, something that, building on from what Courtney was saying about the responsibility being placed so often on people who are suffering, people in crisis, I think the thing Chris said about being told no so many times that you just sort of accept it and you get this sort of defeated position, that's something that really resonated. Lots of stuff about the thresholds to care, so not being unwell enough to cross a threshold where they get care, waiting, and then it takes someone getting to crisis to then get care, and then when you start getting well again, you're back under that threshold. And there's an aspiration, I know, in the 2019 Community Mental Health Framework of things being tailored and personalisable, but this rubs up against the sort of bureaucracies where care is allocated based on these categories and diagnoses. I think, yeah, that's something that really came up, I think, in all three, was about these thresholds. And
is that something you think the committee should be looking at more specifically, the thresholds?
Yeah. And yeah, there was so much other stuff, but I think particularly the re-explaining yourself to different teams and different professionals, not just as a tedious thing, but as Chris really elucidated, like that's actually reliving a lot of traumatic experience, and that can actually harm people and be negatively, anti-therapeutic. And stuff around the social determinants as well. There's a lot in the research about that.
Thank you so much, Kadra.
Yeah, I'm just building on what my colleagues shared. I think for me, something that really struck me and what resonates with our research is just the sheer fragmentations across all these systems, which each of them are overstretched and under-resourced. You would think it makes sense to work quite closely together, resources and information to improve outcomes. Excuse me. I think the other key thing for me is that person-centred approach, enabling people to have choice and flexibility in the type of care they have. So I've been working quite closely with Chris on something called the Black Mental Health Manifesto to really tackle mental health inequalities. And then the last thing for me, I guess, is just really recognising the vital role that charities play. So I think Chris referred to it as buffer services. They are picking up the slack where statutory services, unfortunately, are failing, but are also massively under-resourced, and with things like the upcoming national insurance hikes, that's going to have massive implications for this already underwhelmed part of the system. So I think I'd really urge the committee to pay close attention to that part of the system and seeing it as crucial to the overall community mental health service.
Very helpful. Thank you. Deirdre Costigan.
Thank you, and thank you everybody for coming in today, and it was great to listen to the lived experience of others earlier in today's session. So my understanding is that actually we're not that clear what the need is for community mental health. We actually don't have clear data on that at all, but we do have sort of, I suppose, some proxy data or some things that might give us an idea. And I know we already heard from Ian that he experienced himself a 6-week wait to go onto a crisis team if you're not known to the secondary team. And I think in the Darcy report there was mention of 345,000 people waiting for a mental health referral. So some of that information we can use to get an idea, but we're still not that clear what the perhaps unmet demand is out there. And I think Chris did mention the buffer services that are picking up the slack, as Kadra says, but how do we actually improve the information we have about the level of demand? Because we can't meet it if we don't know what the demand is. Is there
anyone who feels that they
might have an answer to that?
Yeah. Lucy?
Thank you. So I think there is an absolute data issue when it comes to mental health services. There is, it is part of the lack of parity across mental health services and physical health services. We don't have prevalence statistics, or we do, but they're extremely out of date. They're from 2014. And so it's very, very difficult for ICBs, in other words, commissioners, to be able to look at their population and to be able to then plan for that population. And I think the fluctuating nature of mental ill health as well means that there's ever growing numbers of people who are needing that support from the system. And I think, as we heard from particularly Ian talking about how when he went to services and was told he's too well now for certain services, and we also hear people saying that they're being told that they're too unwell for other services like talking therapies, which you can't access if you are experiencing a severe mental illness. So community mental health is supposed to be there for everyone with moderate and severe mental health problems. And it shouldn't have thresholds. So the idea behind the community mental health framework, when it was published, was that it should be about getting rid of thresholds of care and be accessible to all, and that there should be no wrong door to that support. So if someone is experiencing any kind of symptoms, they can go to a certain part of the system, whether that's a GP or a crisis service or secondary care, and then get that support wrapped around them wherever it is in the community, both clinical support and that social support as well. But yes, what we do have is the NHS long-term plan setting out that 370,000 more adults should have access to community mental health services, which was a bit of a finger in the air figure. The good news is that has been met. However, as you say, there are thousands more on waiting lists, hundreds of thousands more on waiting lists. And I think a more accurate statistic to be looking at the moment is waiting times, where we can see that those waiting the longest for community mental health care are waiting more than twice as long as those waiting for the longest waits for elective care. And yet the government are prioritising, saying to the system they must prioritise elective waits at the moment, and mental health waiting standards are not included in that. So again, it's very, very concerning, the data, the very muddy waters, and just the inability for ICPs to be able to really look at their populations and understand how to plan appropriately and to provide the right services amidst growing pressures and growing demand.
Did you want to come in on that?
Yeah, I can't... maybe it doesn't answer the specificity of your question, but add some other things around the edge. Yeah, I think one of the problems perhaps when it comes to gathering data around community mental health services is it's very unclear what they are, where the edges are, where are the boundaries there, and therefore, designing some kind of research project in which you have inclusion and exclusion criteria is going to be extremely difficult, and that isn't just a thing about data. That's also the experience of people who are trying to navigate this system. Is like, what is it? Where does it vary in different areas, etc. So that's the first point. And yeah, the necessity of doing that, of actually understanding and improving community mental health services, it's part of the reason I'm excited to be here today. That there's a lot of speak and effort around reforming mental health services at the moment, a lot of which in very good directions, reducing detentions, reducing police involvement, etc., etc. What you will see in a lot of those initiatives is the assumption or hope that, if we don't have detention, people will be supported in good, safe, accessible community mental health services, etc. But those aren't there. So, it's exciting, the prospect of creating the alternative upon which, reducing coercion in mental health services. And finally, on data specifically, there is also increased talk of co-production, of designing research, reimagining services, alongside people with lived experience. In fact, we do have quite a lot of data. Is it considered data? Do we consider, what people said on the previous panel as data? Is that enough to decide that something drastic needs to be done to improve these services? And I think that is also an essential part, an often missing part of the conversation around co-production, lived experience involvement, etc., is that they will act as nice stories, or often sad stories, to contextualise this kind of work, but actually seem to often not be sufficient to motivate action or investment that we need, the numbers or the real science instead. I think that's something we need to reconsider.
Thank you. So we've talked about demand and the fact that we don't really have the data to tell us what the demand for community mental health services are. But as you said there, we also don't really have clear information on whether we're meeting that demand because we don't have access standards, we don't have waiting list targets. So what needs to change at a local or a national level to more effectively monitor and evaluate access, whether that is targets or something else? Perhaps one of the other two would.
I think putting on what Lucy said, I think the 343,000 is people that have been waiting for over a year, which I think, with the testimony from the first panel, that really puts the stark context of how long that is to be waiting. I think some of the things about what good community mental health looks like, I think we do know on the level of what service users want, people with lived experience, and clinical teams who work in this setting. I think that perhaps the area where there's less known and that there's more uncertainty is around the gap between these aspirations and these principles about what good mental health care is and the actual delivery. I think a lot of what we heard in the first panel are things that have been captured in the community mental health framework, but obviously, evidently from today are not being delivered and haven't been improved on. So it's not sort of worked through the systems. I think there's something about also that the definition of what good community mental health care isn't ever going to be finalised in a static definition, and I think that's going to need to be constantly refreshed as this transformation project takes place and needs to be sense checked and by involving people with lived experience throughout the process to sort of, and what I think would be really great would be involving those people with lived experience through actual sort of data collection and involving them with local trusts to collect and analyse this data and sort of sense check it from the bottom up.
Right. Do you want to add on that?
No, absolutely. I just wanted to build on the points Lucy made about the access and waiting time standards. So there was some consultation with the sector that was done about a year ago with NHS England. We really think that just needs to be adopted, and it draws on the learning from waiting time standards introduced in eating disorder services and early intervention in psychosis. So that's proven. I think one key element that's also missing in the data picture for me is around outcomes. So again, we're looking at weight, access, but is the quality of care good? Is it helping people to recover and stay well? We just don't know that. And I think co-creating what those metrics would look like with people with lived experience is crucial. And then a last final point for me would be we've been advocating recently for the establishment of an independent mental health commissioner so that there is this office at the national level that can look at practice across the system and across all the relevant departments to tell us what is going on in the nation's mental health and if people are getting good quality care and provision, and hopefully we will see some success around that through the mental health bill.
Right, and we're looking for some good ideas like that, aren't we? So that's great. Just final question for me then. And we've talked about, I think, what's known as, you mentioned the severity gap and the thresholds, and Ian gave a good example of being deemed to be too well for services. So are there any examples of best practice, and that's specifically what we're looking for, where secondary care has worked effectively to prevent patients falling between these gaps? Could I come back to Lucy or...?
Yes, so I think in particular I'd like to talk about Somerset.
We are going to later.
You are going to later,
so
okay.
Just to be noted for now. Yeah. We'll come back to that.
Should I wait until later?
Yeah.
No worries. But the theme of that is a no wrong door approach and real integration between primary and secondary care, not just seeing this as two separate agencies with two separate client lists.
Because my understanding was that's, as you've said, was what was put forward as the way the service should be evolving. But, is it actually happening? Is it actually happening in reality that we're looking at, a person-centred rather than there's primary care and there's secondary care? Are people still getting stuck in there, and what can we do to stop that? Does anybody else do you want to respond, Courtney?
Thank you. I think 2 points on the severity gap, or the void, as it's often called. yeah, which is sad that there's even a term for it. The first one is just like emphasising the kind of like cruelty of its existence, of that void, that, you know, we have a national discourse around mental health that, you know, that we should tackle stigma, that people should be talking about their mental health, etc., etc. Often people are falling into this gap because they are being brave enough, wild enough to disclose the extent of their suffering, right? So then people are actually, in their bravery, taking themselves over a threshold and finding themselves with no care at all. Or maybe even the other way, to say, oh, I'm doing a bit better. Okay, you're too well now. You can be in the middle. So, yeah, it feels somewhat incongruent with this kind of emphasis on people being really honest about it, and that, you know, makes it especially sad. In terms of best practice, I think just retaining care coordination, retaining care coordinators. We had it. Where did it go? Or that you know, the experience of our members is that the community mental health framework kind of put that into some confusion. Do care coordinators still exist? Is everyone still entitled to one? Does it have a different name? Is it a connector? Is it a da-da-da? And that actually there's variation across, you know, different localities that it just kind of depends where you live on the kinds of care that you will get. And, you know, that's essential for understanding where these thresholds are, understanding what other support is available, making sure you don't miss deadlines, that you don't end up with, you know, benefits overpayments, etc., etc. So, you know, it's not an innovation, it's just keeping the thing that we had that was doing quite a good job. Thank you.
Thank you.
Yeah, I think care coordinators are... there was something Francesca mentioned about her, one of the things she would want would be one point of contact who has a holistic understanding. That's one thing care coordinators can provide where they're available. I think early intervention teams are a model potentially to take an example from, these services are sort of leading the way in like joining up the psychiatric and the psychological and the physical and the social care, and sort of linking with other charity organisations, employment, housing, benefits, and promoting peer support and lived experience work as well. So they've got this sort of holistic approach, this whole person approach. I think that's somewhere to look for best practice. I think, as Courtney said, some of this stuff's being eroded. There are funding shortages and, the ambiguity around care coordination. And there is a risk still with the gap where people go through an early intervention service for 3 years typically, and then they get discharged back. And there still exists this risk. There is like an off-ramping process and a sort of, you sort of get sent away with like a plan, a sort of reference, you know, if anything goes wrong, remember we filled this out together, here's who you talk, etc., who are your trusted contacts and stuff like that. But there is still that sort of, that area of risk when people leave that.
Thank you. Thank you very much. We'll got some specific questions for Kadra in a second from Paulette Hamilton.
Right, Kadra, lovely to see you again. I better start by saying I've had a long history in mental health, but I also do the associate manager role, so I do section in mental health. So I just wanted to declare that before I open my mouth. But I've known Deirdre from before, so I need to declare that also, I think. Kadra, sorry. Deirdre.
You know Deirdre enough.
Me and names are a problem. Now my question very quickly, Kadra. It's about, my first question is about inequalities and access.
Excuse me.
Now, Kadra, from the work you've done over many years, you know that especially black men, as was highlighted on the first panel, they access mental health services late because 9 times out of 10 there is denial within our communities. They don't know how to talk to they feel some shame about what they're going through, so they access, for many reasons, services are accessed late, and also families sometimes block access because it's not till it becomes quite acute do they get into the mental health service. Also, it isn't diagnosed early enough when people from different groups have issues. also, once it's diagnosed, community intervention, as was highlighted in the first panel, is very hit and miss. It very much is a postcode lottery, and 9 times out of 10, even with the talk therapy, it's 6 sessions and then it's finished, and sometimes it's just not enough and it's not continued enough. Thirdly, what I wanted to say, it's not only black men. We mustn't remember people with disabilities, transsexuals, LGBTQ communities also struggle in this area. So, Kadra, my question to you is, how do we address the factors driving inequality?
Yeah, thank you for that, Paula. So tackling inequalities, as I said earlier, is our sort of bread and butter as an organisation. And as you pointed out, there's several groups that face increased risk of mental health problems. Sometimes this is driven by discrimination itself, causing mental health problems. And then there's other groups who may have like co-occurring issues, including disabilities, etc. I think there's a real lack of like understanding around this, that these are whole individuals who also have lots of other characteristics and identities that need responding to and catering to. But I wanted to touch on a couple of advancements that have been happening that I think we can draw from. So we're really privileged in the mental health sector to have the first anti-racist framework in mental health services called the Patient and Carer Race Equality Framework. And by April, each mental health trust is sort of required to publish a co-created action plan on how they meet a set of competencies to address this. I think we can build from that. So really for us is designing a community mental health system that is designed from the margins for the groups that face the harshest inequalities, and then thinking about ways of improving access and support from there on. Another key thing I think is just, working with community-led organisations. Chris mentioned a few settings like parks, churches, all these other sort of settings where people who might face the most harshest forms of marginalisation are based in. We need to be going to where they are, not expecting them to come to clinical services. So I think rethink around how care is provided and what partnership looks like in this space is quite critical.
Right, thank you for that. I'm not going to ask anybody else because I think you're the specialist. So I'm going to move swiftly on to transitions. This has been a bugbear of mine, I'll just declare that, for many years, because I could never understand why when a young person gets to the age of 18, it just drops off a cliff. And the problem with transitions, you go from children to adults and we lose them till they're 25. They have promised us a comprehensive offer, but that offer has not appeared to date. So my question to you is, what progress is being made in this area, and what actions do you feel we need to prioritise to improve performance?
Yeah, absolutely. This is a personal bugbear of mine too. So next month will be 10 years since the government published a document called Future in Mind, which looked to overhaul services, including addressing that cliff edge. And we're here 10 years later. That 0 to 25 vision, I think, is a bit of a postcode lottery, sadly, depending on where you live. And the idea was to have that period of extended transition where if young people felt comfortable transition into adult services at 18, they could, but they could also stay on to 25, even up to 30 in some areas. There are some interesting shifts that are happening that I'd like to point to. So, for example, we've been campaigning on open access mental health hubs for young people in the community. That does go up to 25, and the government has committed to that as part of the Young Futures programme. There is a core focus on 10 to 19 with that, so it's quite key that we see that bridge up to 25 as part of the services. And then the other thing I'd point to is the student population. So our colleagues at Student Minds, they've been doing really phenomenal work around the university's mental health charter to really address that for students who might be out of their home setting. How can we continue care and support for them in those settings? So there's some promising shifts in the space, but I think one thing we really need to get a hold of is the sort of battle that you tend to see between child and adult services, and like who's responsible for commissioning for this cohort of young people. And, you know, that, as you said, is the time where we see a marked deterioration of mental health needs. We really need to get it right for that cohort to ensure, you know, that their life chances are protected in the long term.
Thanks. Does anybody else want to add to it? Lucy?
Thank you. Just really briefly, I think it's worth the committee looking into early intervention and psychosis services. It's a really fantastic example of a service that is for all, and it's based on a presentation rather than a diagnosis. Obviously, because it's for first episodes of psychosis, so it does tend to see the majority of, you know, younger people. And you know, it's got waiting lists for 2 weeks, it's got really clear standards, and then very holistic support when people do get access to that support. Again, though, the transition from then having that support to then going back into the community is very cliff edge, but I think that is what a lot of people see community mental health being a much greater, larger, multi-layered version of, you know, if we can get EIP right, then we can get other services right as well.
Can I add one more thing? Sorry. I just forgot to mention. It goes back to Harry's point earlier about thresholds. One thing we hear a lot from young people is adult services have much higher thresholds than children's services. So that's also something that needs to be considered.
Right, I'm going to stop there and hand back to the chair. There's lots of...
Josh Fenton-Glynn.
Thank you so much. So one of the things I think that kind of came across today was kind of patchy access and experience of mental health provision. CQC figures showed that less than half of those who actually managed to access the mental health provision said that they got what they needed. I think it was 39%. Why is that? Probably Lucy.
Various reasons. I think increased demand over the last sort of 5-6 years, and then workforce not keeping up with that demand. You know, there's significant workforce shortages. I think there has been a lot of investment and a lot of focus on the mental health workforce, and we have seen improvements, but nowhere near enough compared to demand that we're seeing.
And I just very quickly ask you, just for the report, is that because we're not training enough people? Is that because not enough people are going into training, or is that because we're not employing enough people?
I think there's a kind of, because of the long amount of time it can take to train, obviously psychiatrists, but then also mental health nurses and so on, there is a lag time. So I think there has been investment since the long-term plan and the workforce plan, but there is a lag to then us being able to see that that workforce actually coming in and providing support. And in the meantime, we've seen a lot of retirements as well, and a lot of people moving out of the workforce. I think there is a vicious cycle problem as well with mental health, where the more we see people go into working in mental health in order to do good and care for people, the more we hear about how that isn't happening in mental health, and that you'll in a lot of cases when we talk to professionals, they say I'm basically here just as a gatekeeper, not to actually care for people. There is a real problem with culture and people wanting to do a good job and not to go in just to be a gatekeeper. So I think, workforce, but I think the solutions to that there are so many solutions, and it doesn't just focus on the clinical workforce. It's really about looking at the voluntary sector and other forms of workforce, like peer workforce, to be able to be there to support people. And again, as we heard earlier, a lot of what people have found the most beneficial to their recovery has been peer support, navigation, and the voluntary sector stepping in and providing that real local community and kind of creative art form of therapy and so on.
And then just kind of moving on to that, I think maybe more for Courtney and Harry, but are we kind of a little bit too focused on expecting people to be the perfect patients, no co-occurring conditions, and things like that, and what kind of models help us move beyond that?
Take that first.
Yeah, I don't know what I have to say about the expectation that people are perfect patients. Yeah, that's nothing springs to mind on that particularly. I think, I would emphasise the point that there in dealing with increased demand in mental health services, we are seeing trends in lots. It takes some thinking to join them up, of how to, in essence, turn people away from mental health services, that there's kind of a nudge in that direction as well. So I think, if you look at changes in welfare reform, in, as I said, these innovations that are happening in mental health services to deal with high-intensity users, frequent flyers, the suspicion becomes, somewhat that the perfect patient is just not a patient, that they are just not, they are not the demand, which is, of course, horrible. And then to build on a point as well, that we've heard, often that, excellence, or at least in the previous panel, that the excellence of the third sector, particularly, this peer workforce that you're talking about, etc., etc. And I think that work is essential, and, I'm biased, perhaps, in that regard. But to emphasise that sector is one also in financial crisis. That is one that is also chronically underfunded. And I have some numbers here. There was a brilliant piece of research that came up very recently by Disability Rights UK, which was looking at the work of disabled people's organisations. So those are organisations where the majority of people who are, staff on the board are themselves people with lived experience. That over 90% of DPOs are seeing an increase in services, but over 40% of those do not believe.
Wait, DPOs?
Disabled people's organisations.
Thank you.
Thank you. Whereas over 90% of those organisations are experiencing increased demand. Over 40% also don't think they're going to financially survive. For the most part, what we see is like large-scale charities getting huge amounts of funding and money, and then these smaller organisations, the praises of which have been sung today, are facing huge barriers when it comes to accessing funding, being sustainable themselves. If that is a workforce, we are putting the emotional labour of picking up the slack of a mental health crisis in failure on people to do the emotional labour that system is not doing. So that workforce is also, requiring support and care, but is having additional burdens put on them.
Yeah, I think with your question, I'm thinking about it from two angles. I suppose one is the sort of service user perspective on these things. Even if you get through to services and they might be adequate, if you've waited for over a year, that you probably don't feel like you've gotten what you required. And then there are a lot of the other issues which have been discussed through the first panel. I think on the sort of more institutional or systemic side of things we know about are the workforce shortages, funding pressures, and disruption around sort of team restructuring, and all of these have been compounded by the COVID-19 pandemic as well. I think it's challenging, it's really difficult to implement transformations when systems are strained and exhausted in all these other, being pulled in all these other directions, and staff get burned out as well, like especially the sort of moral defeat where you go into these sort of professions wanting to help people and it's not happening. So I think all of those are factors. And there's a real fear, we sort of feel from some of our colleagues that transformation, if it's just constant transformation, then things aren't given a chance to sort of mature and put down roots.
Thank you. I really appreciate you all taking the time to answer my question.
Thank you so much. Andrew George.
Thank you very much. I was going to ask two areas of questioning. The first was that in relation to what you thought that a good community health services look like. But I think that actually following the excellent first panel and what you've said already, I think we can see the component parts and we can probably collate that ourselves, if you don't mind, and also because we're running slightly behind time, and I'll be under pressure otherwise from the chair, quite rightly, on this. Therefore, the second area of question was that of co-production. And I just remember when I was sort of indirectly involved in a charity that was coordinating mental health user groups more than 3 decades ago. The whole concept of co-production or user involvement in the design of services has always been there. And there's this sort of sense of, well, we're going around it still further, and why has it failed? I mean, you know, I'll use the word failed. We're still there, and we still feel that we're not, co-production doesn't appear to be happening. So my question, and because of time, I'll pick randomly at Courtney and Kadra to answer this. In terms of co-production, is the reason why we're not making progress because the service providers smile benignly at you but actually go away and disagree? Or is it that there's a more mundane kind of resource, or rather lack of resource reason for it? And indeed, just a kind of follow-up, if you like, to it, which is, if it's the latter, I mean, does co-production provide a method by which the service can become more resource efficient, I suppose? I mean, is that too many questions in one? But hopefully, I don't know. We'll start with you, Courtney. If you don't, yeah.
I'll try my best with all of those. I think probably the main point that I would like to make around co-production, despite being a person and from an organisation who advocates for it, is actually it's a really complicated and hard thing to achieve. If you have a situation in which you have someone, experiencing so-called severe mental illness, and then you have, the kind of like monolith of a mental health trust, there's a power dynamic going on there that we need to be honest about. Dealing with that and attending to that is going to take quite a lot of work, and I think the thing that's happening is there's becoming a real lack of faith among service users that what will happen is we will have an instance in which someone with lived experience gets to speak or just join, and then all of a sudden we have an output which says it was co-produced. Is that necessarily the case? I'm not sure. And there needs, genuine co-production requires some very mundane things, as you say. You need to level the playing field, so to speak. People need to be paid for their time, they need to be supported for their time, etc., things like that. In terms of the dynamics, there needs to be an equal willingness to do things differently, right? What we have is, co-production initiatives in which people with lived experience come in and get to choose, right, would you like us to do option A or option B? Not what should the options be, how do you want this to run, how do you wish for us to work together, etc., So, I would argue that doing bad co-production and still claiming it is probably worse than saying this is really complicated and I'm not sure we've achieved it, but we have done X, Y, and Z, and these are the things that we were able to do. I think there's a truth telling that needs to be done there, because it is an extremely difficult thing to achieve. It's worth doing, but it's not easy.
So is it all lip service, do you think?
Yeah, I was going to say, may I defer to Harry, because I think he's going to
have
have
some
some
brilliant
points.
Okay, yes, fine, yes, thank you, Harry. Yes,
thank you, Kadra. Thank you, Andrew. I'll build on what Courtney was saying. I definitely think we do see an inflation of terms. So the way I generally think about this is with Arnstein's ladder, which is a framework where you have non-participation at the bottom and like equal partnership, co-production at the top. Yep. And what often happens, or the inflation of terms happens, where things in the middle, like consultation, involvement, which are great things to do, but they're somewhere in the middle of this ladder, get done, but then it gets called co-design and co-production, which is, an inflation of the terms. I think the real challenge that comes with doing proper, like meaningful co-production is that it is ultimately about sharing power, and it does cost money to do substantive involvement, to have people meaningfully involved in projects and to be reimbursed for their time, paid for the work that they do. It does cost a lot of money, and it involves devolving power to people with lived experience. And then, so I think within NHS structures, you might have sort of leaders who don't feel like there's a lot of they don't feel particularly empowered, and they don't feel particularly flush with cash, and they're being asked to share power and spend money. There's a real friction there. yeah, I do think there's lots of initiatives around lived experience involvement and pathways. I mean, personally, that's how I've sort of, through my recovery, I started doing lived experience work and got involved in a research co-design project, which sort of led on to what I do.
If we as a committee wanted to go and look at a location where co-production has been handled well and sincerely and with meaning and has resulted in satisfactory outcome, where would we go, or can't you point us anywhere?
I think we definitely, McPin have definitely been in projects that we would confidently proclaim have been co-production. I think, yeah, from my sort of anecdote, I definitely got to a sort of ceiling with AWP, but they have got definitely elements of co-design and a robust sort of lived experience pathway.
Right.
I think.
It'd be really useful if any of you could kind of point us to any.
Write to us afterwards.
Yeah. I mean, you don't need to do it now, but certainly point us in the direction of any location where we could, identify, a place where co-production has really worked. It's resulted in outcomes which we can be proud of.
Yeah, we'll definitely write to you.
I mean, it's worrying that no one's sort of jumping at the opportunity to tell us that, oh yes, there's this example. That is worrying. Oh, go on. Yes.
Yeah, we can definitely share some afterwards, also conscious of time. But there's, for example, Coventry and Warwickshire, where they work with the Cultural Inclusion Network, which was co-produced in and of itself, and then worked in partnership to then design what the transformation should look like in Coventry and Warwickshire. And then develop this REACH service, which is all about peer support in terms of then delivering mental health support in the community. So that is in our submission, and we can share more on that.
I mean, I imagine the worry is that there's a concern amongst providers that this will result in raised expectations and unfulfilled expectations and more resource. But I mean, surely there must be examples where one can identify that actually involving users will result in more resource efficiency.
Absolutely. And I think there are some really amazing clinical leaders out there who've really driven co-production in their places. There's a number of examples, I think, in our submission, Norfolk and Waveney as well. Sheffield, Somerset again. But resources are now so tight, and those clinical leaders don't have ownership over their budgets anymore. Budgets are being signed off by financial directors and CFOs. They're not prioritising co-production.
Thank you so much, Dr. Becky Cooper.
Oh, thank you, Chair. Thanks so much for coming along. Really interesting to hear, and the previous panel as well. I wanted to ask you about integration of services in the more broad sense. So I wanted to ask you about integrating mental health services with physical health services, and whether you think that there are examples of good practice in this area, and what more could be done. For example, we heard from the NHS Health Checks team a couple of weeks ago, and Darcy did highlight that there was some good work being done in that area, but I'd be really interested to hear your thoughts on how those two services, which have been pulled apart in a slightly bizarre way, could be better integrated. So I don't know if Lucy, you'd like to start with that. Thank you.
Yes, of course. So one of the great initiatives, which again we heard about earlier, is the physical health check, which everyone with severe mental illness is entitled to annually. There is a target for that, or there was a target that's now no longer in planning guidance for the NHS. So it's no longer a target for the system to increase the number of physical health checks. But this is, so talking first about what the physical health check does and the benefits of it, is that it is that access point for primary care for people with SMI to then be able to get a holistic view of their health, how medication is impacting on them, other lifestyle factors, and then they should then be signposted and transferred to then other support, whether that's smoking cessation services, weight management, diabetic health checks and so on. There tends to then be another kind of drop-off point there where there isn't that follow-up support. But I think the first issue really is that people are not accessing their physical health checks, understandably, and the numbers of people who've been accessing them over the years has really fluctuated. So at one point it was, and I think at the moment it's 60%. In previous years it's gone down to only 20% of people with severe mental illness accessing physical health checks. And I think without that really, really focused, sustained drive from systems to prioritise physical health checks and support people to access them, we're going to see that drop off, again, undoubtedly over the next few years.
Okay, thanks so much. And I just wonder if any of the other panel had any thoughts about how physical health is integrated into mental health services. It does, sort of looking at how the services are, it does look quite separate. And I just wondered if you had any thoughts about sort of bringing the physical health into the mental health space, or vice versa, putting mental health into the physical health space. I don't know if one of you would like to take that.
Absolutely. I guess I'll pick up on one area where we see these issues particularly pronounced, and that's with people with co-occurring substance use services. Unfortunately, due to the cuts in public health, that's been really undermined, but there are some examples that we can share with the committee where they have integrated that provision and, see the two as issues that kind of exist hand in hand. But if I may, I guess there's also the previous panel talked a lot about social determinants, and there are other services that need to be integrated within mental health and physical health services. So for example, housing support and welfare advice. There's a great example in Hampshire and Isle of Wight where they integrated a citizens advice service within a mental health inpatient setting to provide that sort of comprehensive ongoing support for people. So look at some of those examples and see how we can build on that too.
Perfect.
Very helpful. Thank you very much. And actually that takes me on to just a few more questions about social determinants. Perhaps if I could ask Harry if you've got any research on this. So we spoke about housing and welfare need integrating, but also businesses and workplaces. Have you got anything to show, to what extent do businesses understand severe mental ill health and ongoing needs of people who have them every single day? Do we have a sense that business has really wrapped its head around this, or is it sort of stuck at the time to talk at a mental health first aid, but that's not quite the same level? Has anyone got any research or data that points to this as an issue? I'll start with Harry potentially, but if others want to come in, that's helpful.
Yeah, not that I've prepared today. Do you mean in terms of as employers?
Yes.
For people? Yeah.
So to keep people thriving at work.
Yes.
As we saw from our first panel, you may have a severe mental illness, but actually you're an incredible person, and as Francesca, I think, very beautifully said, I want to be creative at work and live their best selves. But to what extent do we have businesses that genuinely understand this in this country? Does anyone else have, Kadra?
Yeah, happy to comment on this. I just wanted to point the committee to the IPS model, so individual placement and support. So this is a internationally recognised model, 20 years worth of evidence, and it's a principles-led model that's been co-created with people with lived experience. And so, as Francesca said, this is about providing that in-reach employment support and advice. Some of the principles include things like honouring people's preferences for what types of work they want and how important that is for them to kind of, recover and sustain and get into work itself, integrating employment support within mental health services. So, I think this is quite key. The long-term plan looked to expand this provision, and we hope that that's taken forward as part of the forthcoming 10-year health plan as well.
Mm-hmm. That's very helpful. And we know that there are disparities of performance between areas in terms of integration, so turning now a bit more to disparities across the country. I don't know if, Lucy, that's something you feel able to comment on, because we'd be really keen to know, is it the same in urban environments compared to rural environments? Is there a north-south divide? How does this look across the country?
When we talk to our kind of colleagues in ICBs around the country, they very much say there is a difference between urban delivery in urban areas, mental health support, and then rural areas. And I think, again, if you were to speak to commissioners in Somerset, I think they'd have a lot to say about that, particularly around the fact that a lot of reporting is based on evidence from urban areas as opposed to rural areas. But in terms of integration, I think it's a very, very interesting point. I think what we see more where there are good practice areas of integration as opposed to poor practice is really around relationships between these areas and the kind of power imbalance, which usually stems from funding. So, you know, how is the local authority doing in terms of their funding? Yeah. What's the NHS looking like? And what's that kind of power balance? And then how the voluntary sector is involved as part of that. Are they seen as a genuine equal third partner? Or are they just seen as, you know, lots of little charities and maybe one big provider who they just want to kind of give a bit of money to and to do a few bits and pieces rather than genuinely being part of that decision making. And I think the introduction of alliances has been a bit of a step change in how we can really integrate the third sector alongside local authorities and the NHS. As a way of getting rid of the trust issue between charities and the competition for funding, but bringing the charity sector together and the community groups and faith groups as well, and being able to flow money through so it's much more sustainable, but that money goes to the right people delivering, who are the real experts, whether that is, you know, the big local charity or the really local community groups.
Yeah, so I'm hearing there's a lot of stock put on individuals to demonstrate leadership within systems, but a barrier could also be financial flow. Is that a fair point?
Absolutely, yeah, a big barrier.
Thank you. So here is your chance to talk about Somerset, please.
So
you know, crack on. So tell us about Somerset briefly, please.
Yeah, really briefly. So Somerset was one of the early implementers of community mental health framework. So it has had another 2 years alongside some of the other ICBs in the country. It's had another 2 years as compared to other ICBs. And what I think some of what it's doing is basically ensuring that anyone who is experiencing mental health problems, and there is a particular example that we talk about a lot, where someone was in mental health crisis on a bench, on a kind of roadside bench, and happened to speak to someone who then kind of took them into the local crisis centre, and from there was then able to get all the support wrapped around him. And not just that kind of immediate crisis support provided by the local charity, but then to be able to immediately then get the NHS support, which happened, you know, in so many cases in Somerset is co-located, along with then other support around, money advice, particularly housing support. There's the most amazing form of support provided by a kind of co-located charity to an NHS site, where it supports people who've migrants, so people who particularly have come from Ukraine and other parts of the world, and provides, it just gets rid of the barriers, the language barriers, but also these kind of referral barriers that just in so many cases mean that people have to meet a certain threshold, as we've talked about, to be able to get that support. So I think the three key words that have been at the centre of rolling out Somerset has been no wrong door. Yeah. And it really is true that I think that, you know, there has been research, peer-reviewed research into this, which has found that does mean that individuals who are experiencing mental health problems can then get that wider support, whether it is from primary care or secondary care, local authority, the voluntary sector.
What about the police?
Good question, and I think there is a way to go. I think if you were to bring someone from Somerset to the inquiry, I think they would say this isn't the perfect solution, and they're not at the end of the journey yet. You know, there's still so much more to do, and probably more integration to go as well. You know, ambulance, for example, it's a very rural area, and I think there are issues with there being ambulances available for people that they've been trialling a kind of mental health ambulance, and you know that's not necessarily been that successful, but I would definitely speak to them about that. But I think the statistic that is so powerful, which really demonstrates the success of the area, is that we're now seeing, or we have seen over the last few years, 15% reduction in A&E presentations and 16% reduction in admission to inpatient. And that is the case for adult mental health, because there has been this transformation in adult community. unfortunately, we haven't yet seen the same for community mental health in Somerset, and there hasn't been the same transformation in children and young people's mental health support there. So.
Thank you. And so it's an example of best practice. What is the mechanism by which this could get rolled out elsewhere? How is, the Secretary of State often talks about best to the rest, but how is that actually theoretically going to happen? Is it happening? Are people noticing?
Definitely, it is happening, and it's very much, it is delivering what the Community Mental Health Framework said, and it definitely is happening around the country. And I think there has been a real programme of, NHS England promoting what's happened in Somerset and sharing that best practice. I think the mechanism now for rolling it out is the Secretary of State's drive to roll out neighbourhood health. And what our real plea is that he puts mental health as a core part of that, because it's already there. We've already got the frameworks for it. It just needs to be said it's a priority again. When systems are really focused on elective waiting times now, systems need to hear that community mental health is the priority, and the rollout of 24/7 mental health services is the mechanism of doing that. And then the Secretary of State will have, that as a ready-made solution there rolled out, really aligned with his shift from hospital to community.
That very clearly. Thank you. Deirdre Coskin.
Thanks. Just very quick on that. It sounds like a brilliant model here in Somerset, but despite what you said, I think it's not rolled out across the whole country or anywhere near that as yet. And sometimes it's money that is the barrier to these kind of initiatives being rolled out. So did it cost them more money? Have they done any sort of cost-benefit analysis that could be shown to other areas of the country? Because, you said it actually had a reduction on A&E presentations. So overall, it may actually have saved money. But is there any analysis like that can be shared?
That's a very good question, and one we can go away and look at and share further information on. And I absolutely agree, it's not rolled out across the country at all. I would say they have the same amount of money as everyone else, though, and it's really about the relationships and what they did with it. And I think the real leadership to drive this forward, and people with lived experience have been at the centre of designing and delivering it as well.
That's extremely helpful. Thank you. Anybody else?
Thank you. So I'm going to ask a bit more about the community mental health framework. So you've kind of touched on this already, started in the Somerset example to the aspects of success. Rethink, I think, before has described the framework as a once-in-a-generation opportunity to change care and support for the better. To what extent has the rollout achieved this ambition?
That's a really good question, and unfortunately we don't have a clear answer to that because there hasn't been a national evaluation on it. There have been pockets, there have been fantastic evaluations by McPin and Centre for Mental Health on certain aspects of it, but we haven't seen a national evaluation. And with the government's, again, wanting to roll out 24/7 mental health, we need the evaluation to be kind of happening now to be able to then make the case, because this is always what holds mental health back. When there's no evaluation, commissioners can't keep proving to their financial directors that this is what they should be investing in, and then everything falters and stutters, and attention goes elsewhere.
Your key ask really is evaluation of the framework. I don't know if anyone else wants to comment about the framework specifically. If not, I'll kind of move on. Great. I mean, it's whilst we don't have clear evaluation, we've certainly heard that there's a sense that there's a lot of variation. We heard that in witnesses earlier. There's clearly massive variation in services. Do you have a sense of building on Deirdre's question about kind of financing? Are there other barriers why adoption of the framework might not have been as quick or as effective as it might have been?
I think the pandemic happened right at the start of the rollout of the community mental health framework, and interestingly, if you speak to Somerset, they say they use that as a reason for kind of just getting rid of all sort of red tape and bureaucracy and just putting everything behind it and driving it forward. But that absolutely wasn't the case in the majority of places. So there was supposedly a 3-year rollout of community mental health framework. 1.5 of those years was during the pandemic. Then we've had another 1.5 years of which demand soared. There's been so many sort of setbacks and issues, and this is I think, as we've said before, this is a long-term piece of work. This isn't just a transformation over a few years and then something's done. This is a really complex, multi-layered, multi-agency transformation of a whole range of services for a whole range of people with many, many different conditions. So it needs that really consistent support, investment and focus from all the commissioners and all the people involved. And I think that has, all these kind of stops and starts and just all the other pressures on the system are, some of the biggest barriers really to continuing to roll this out.
Helpful, thank you. Knowledge exchanges, evaluation and the evidence that we've seen, they suggested that there's little robust evidence, no kind of clear blueprint for commissioners and services to follow. I mean, you've pointed to a good example in Somerset. Do you feel that is the case? Would you share that evaluation of the situation, that there's no clear blueprint for commissioners or service providers to follow that's evidence-based?
I probably wouldn't agree with that. Obviously, I'm not a commissioner, so I can't speak for commissioners, but I would say that, there is a framework, and the whole point of the framework is it's supposed to be really high level and national, but that it's supposed to be really place-based and locally delivered, and for commissioners to work with their populations on a place-based level, so a real local level, to then look at what that population looks like and what they need and how they can tweak and change what's happening and what the kind of local assets are to then be able to deliver it. So you just can't have, a national prescription. You can have guidelines and frameworks, and I know there are going to be more principles.
Is that one of the reasons that adoption's been slow? If busy commissioners commissioning a range of services don't know where to look for what good looks like, or I think we've heard before there's such variation in what is provided. And in some places, there's, as you point to Somerset, there are services that are working. Are there models that could be, obviously there's always localisation, there's always need to be culturally sensitive services aligned with users, but rather than have to start from scratch just with a headline framework, would it be helpful to have more of a sense of what interventions generally have evidence, do seem to work, rather than just...
And again, I think a lot of that is out there. So I know Centre for Mental Health have done a lot of research into this. Rethink, we've published a number of guides to the system which set out that, share best practice. We've done webinars with thousands of attendees from ICBs. I know NHS England have as well. I think there is a lot of information out there. I think it needs attention given to it again, and prioritisation, and the headspace for commissioners to be able to focus on it again. And so I think the route to doing that is if the Secretary of State wants to set out neighbourhood health as the priority, for shifting hospital to community, put mental health at the centre of that and say, there is some progress. Let's really bolster this now. Let's really go for it and give it another 3 years of real focus. And really roll it out again, along with, we can't get away from the fact that funding is absolutely needed, and there was ring-fence funding for 3 years, and then from last year there wasn't ring-fence funding, it just went into the general pot. So with all the pressures, that's going to be going to different things. So.
Kind of the sense you've got is the framework is still the right model, it's still what should be pursued with those barriers kind of.
Yeah, and I think the framework should and has evolved somewhat as well to include crisis as well. So I think this the pilots of 24/7 community and crisis are the real kind of gold standard, and they are so local and place-based. But I think that's what we should be aiming for everywhere. Anyone who's experiencing mental health need or crisis at any point in a 24-hour period should be able to access some form of support.
For our transcript, it's probably worth saying the panel in general are nodding their heads as you're saying this. Yeah.
Great, thank you. That's the end of my questions.
Oh, thank you so much. Jen Croft.
Thank you, Chair. And you'll be pleased to know I'm the last person. So I will try and I'll be trying to be brief. Thank you, John. So I listened with great interest, particularly to the first panel today, about kind of what doesn't work. I think as a committee, we're very interested in what does work, and looking to what the government should perhaps be doing. We've got the 10-year plan that's being consulted on. I think it finishes tomorrow or Friday, I believe, the consultation. What would you want to see in that 10-year plan as a commitment from government to delivering? And I'd like to be quite specific about for SMI mental health rather than mental health in general. And that's a question, I guess, to all of the panel. So whoever wants to go first.
Happy to kick off. I mean, I guess a couple of years ago, there was a big national consultation on a 10-year strategy for mental health, of which I think nearly 30,000 people shared their views. So there's a good grasp of like the need there from people with lived experience. And I really think the 10-year plan should honour those perspectives and recommendations first and foremost. I think for me, really, it's that integration and strengthening accountability. So whilst we don't want to be too prescriptive nationally, we do need to get a sense of like where funding is going and what impact that is having, and how can we have more transparency of that information on outcomes and experience, really.
Thank you. Harry, do you want to go next?
I have an example of something that I think is good and relates to a lot of what we've discussed. I hope it won't be too long. It's around a peer walking group intervention that was sort of trialled and evaluated, and I was involved in as a peer support worker. And it sort of, I guess I'd characterise it, it's a very low cost and low risk intervention, and I think something about fostering and incubating a culture where people feel sort of able to sort of promote these low-cost, low-risk interventions is really important. It was effectively for people with early intervention services, group walks, which were sort of gentle exercise, talking about the physical health, and gentle social contact, and that more holistic element, all those things that people we've discussed have been missing. But there was something where we did our evaluation and we presented this at the Royal College of Psychiatry, and after the presentation, so many people came up to us from other EI teams and said, "How did you get permission to do this? Oh my God, you got permission to do a walking group." And I'm really not exaggerating. People came up to us "How did you even get this off the ground?" Which I think is a real indictment of the risk-averse culture and how brittle people feel in these systems. And so something to liberate people from that risk aversion and foster these peer groups and grassroots sort of low cost, low risk interventions, because that can grow out of places, and it can be place based, it can be around, it can be led by the people from those sort of areas. And
Thank you.
Thank you. It's going to be hard to be succinct. I'll try my best. I think as a catch-all approach would be to take a care first rather than cost first approach. And what we'll see is increasing emphasis on the cost of those living with severe mental illness to the economy. That is the discourse around, welfare and benefits reform at the moment. That kind of costliness of the unwell is what is driving the creeping privatisation within mental health services. So, like I said, the SIM programme, or another one, Oxyvision, you might want to look into. We've written about it at great length in our evidence submission, so you can see it there. This emphasis that mental health services are worth investing in, they might be worth spending a bit more on, actually, and not because that will drive productivity or boost the economy, but because that's the right thing to do, that people matter. We care about a world in which people wish to be in it, and that just in itself is a better world to be living in, rather than we need to reform mental health services because it's too expensive to have people living in long-term distress.
Do you think the mental health investment standard is the best mechanism to ensure that funding, or should it be increased? Should it be extended? Should it be something completely different?
I think Kadra's going to be a better person to answer that specific question than me.
Yeah, I mean, I think it's been an important mechanism for, driving increases in spending, but that alone is not the solution. I think, we need to have wider reform, and crucially also thinking about the underinvestment of councils and their role in it. So that by not addressing the social determinants, we're amping up demand for mental health services when things could be addressed and people could be supported much more like upstream in the system. So,
Thank you. Lucy, got the last word.
Thank you. So I think the mental health investment standard, it is a safeguard. It's not really anything more than a safeguard, but it's a really, really important one. And we heard from commissioners just before Christmas when we were concerned about the mental health investment standard not being in the planning guidance, that they were basically facing existential threats to their funding pots because, it would no longer have been protected. The money would have all gone over to physical health. And we've seen historically that happen, as was in Darcy. But two things I'd really like to see in the 10-year health plan. Two I've already spoken about already, to be honest, but it's putting mental health as a central part of the neighbourhood health offer and rolling out mental health as part of that. Again, not separating out mental health as something else over there, but if you're rolling out neighbourhood health, put mental health as a central offer into that with associated funding. And then finally, putting mental health waiting times on a constitutional footing alongside elective waiting times as well. Again, always driving towards that parity of everything, not telling systems that they can prioritise physical health over mental health. And that both of those things will then enable systems to prioritise community mental health and really give it that bolstering and focus again.
Thank you. And I just one final question, probably a little bit out of left field, but to what extent do you think that successful localised mental health care, and particularly for SMI, comes from commissioners kind of getting the SMI landscape? I think Courtney's spoken very well on seeing investment in mental health care as a good in and of itself because of the people who it benefits. Is there a feeling that if it works because people understand that people with an SMI mental health condition, they're generally not going to get over it and you're not treating to cure? Or is there something more fundamental about they can follow target-driven things, but you actually need someone there that gets it, and how do you make that happen across the country?
I do think where we've seen it really been driven forward is where there's really interested, passionate leadership at a commissioner level, whether that's clinical leadership or otherwise. So a lot of the examples we've provided, it is where there are people who really understand it and are so passionate about it and have just driven it forward, even when other people in the ICB haven't necessarily been. But it, that is a concern, and it shouldn't be like that necessarily.
You think across the country?
I don't think it's a kind of sweeping statement of people getting it or not. I think commissioners are unbelievably stretched, are having to make really difficult decisions. I think the Secretary of State said the other day that the reason why he's got a thinner planning guidance is because ICBs need to commission less. And that's really concerning because mental health is always one of those ones that then just becoming the thing that drops off and is not prioritised, especially if there aren't the national targets. I'm sure there are many cases of people not necessarily getting it because it's really complicated. But I think there's a lot more going on, and I think commissioners are having to make trade-offs daily, and I hope that's really understood amongst politicians as much as we kind of see day to day when we're talking to commissioners who are just going, I'm sorry, I can't. And it's not because I don't want to, I just can't at the moment.
I think I'll just add it is important to acknowledge the sort of stigmatising narratives at the moment around mental health and how that's fueling that lack of understanding and compassion from maybe decision makers nationally and locally. So we run several networks where we support champions, mental health champions at the local level to provide that educational sort of support, if you like, bringing in research, people with lived experience. And it takes time, but it's a safe space for them to ask us any silly questions and to also hear about how other areas are addressing severe mental illness. So happy to share those examples too.
That'd be great, thank you.
Well, thank you so much, all of you, for being part of our panel today. Thank you again to our first panel who stayed in the room and delighted that you stayed with us. We now come to the end of our session. Order.